Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar about inflammatory markers in eosinophilic gastritis. Dr. Ashley Pyne is a dietitian researcher involved in clinical laboratory work focused on eosinophilic gastrointestinal disorders, also known as EGIDS, at the University of Utah. Ashley is passionate about understanding how diet affects inflammation in EGIDS and what markers or testing can be developed to manage the disease. Welcome, Ashley.
Great. Thank you, Jennifer, and thank you, APFED, for the invitation. Let me get my slides up. Okay. So good afternoon, and I will be going over today the known markers for eosinophilic gastritis and presenting on research that we've conducted looking at inflammatory markers and eosinophilic secretions and how they are specific to patients with eosinophilic gastritis. I'll first just note that I have nothing to disclose, but I'd like to acknowledge before moving on all the co-authors, collaborators, and research coordinators that have made this work possible, as well as some funding support. Just a quick overview, what I'll be talking about. We'll go and jump into the prevalence of EOG and some of the diagnostic barriers for non-EOE agents. We'll discuss what inflammatory markers are known currently, our research aims, and then jump into the research talking about patient cohort, our methodologies, the inflammatory markers that really result that we see in the gastric secretions, and then follow up with our conclusions and future directions for the research. Before moving on, I just kind of want to make sure that I clarify the nomenclature that I'll be using throughout the presentation. So in 2022, the International Consensus Guidelines updated the nomenclature for eosinophilic gastrointestinal disorders. And so any location with eosinophils outside of the esophagus is referred to non-EOE agids. And then EOG is specifically referring to eosinophils that are isolated in the stomach. And if a patient has EOG with other organ involvement, then we would want to specify that involvement. So it could be EOG with esophageal involvement or eosinophilic gastritis with small bowel involvement, and you'd want to specify the location such as duodenitis. And so for the presentation, I'm going to simplify and just refer to a lot of the cohorts as EOG. However, I want to mention that a significant portion of our cohort has both eosinophil involvement of the esophagus as well as in their duodenum. So the prevalence of EOG is rare. So Pesky et al. Had found in 2019 that EOG affects about 6.3 to in 100,000 person, with eosinophilic gastroenteritis at 8.4 per 100,000. And this was before the nomenclature change. And just to put that into reference, for EOE patients, the prevalence is about 56.7 persons per 100,000. But even though we don't see it as prevalent as EOE, we do see that it is increasing in prevalence over the years. And this is the graph from Pesky and all. And what we see is that it's not really known how much those non-EOE agids overlap with EOE. So there's varying reports and studies. One study found that only 40% of their participants had eosinophil involvement in more than one location, where another cohort looked at 87% of their patients had involvement in more than one location. And in our own cohort that we see at the University of Utah, we do see a lot of overlap between eosinophilic gastritis and other organs. And there is diagnostic criteria for EOG. What has been set by the clinical guidelines is more than 30 eosinophils in greater than or equal to 5 high power fields. However, one study found that a high power field of over 33 eosinophils had a good specificity and sensitivity for the diagnosis of EOG. But I think the problem with these diagnostic criteria and for patients and the pathologists that are reading these is that eosinophils are just normal tissue residents in your stomach and the duodenum, and so this can lead to difficulty kind of identifying the number and the cutoffs, and there are varying numbers of eosinophil cutoffs in studies. So as you're looking at kind of what's been included in past studies for EOG, that's always a confounder. But I think what's really important is that EOG and EOD is delayed by almost 3.5 years in most patients that are presenting with symptoms. And so a great paper by Sheehan and al. Looked at the literature and identifying patients with EOG and those characteristics. And what they found was a lot of barriers were of diagnosing EOG included just the under recognition of EGIDs by healthcare providers. The fact that there's limited biopsy collections could be a big barrier to the diagnosis. And then the third was a lack of access to pathologists to actually count those eosinophils in those tissues. And so this really points to the need to find other markers for disease. And what's been in the literature is looking at your RNA shifts. So this is kind of, the RNA acts as a messenger that carries the instructions from your DNA to what's actually going to be encoded into protein. And then the other sort of umbrella of the research is looking at pro-inflammatory proteins, specifically cytokines, and these are pro-inflammatory proteins that are really controlling the growth and the activity of your immune system. So cytokines' jobs are sort of to help transmit various signals to help with cell survival, to help cells increase by number or proliferation, to help with cells maturity, and also to promote functional activity. And then a subgroup of those cytokines are chemokines, and these are specific cytokines that make immune cells move towards a target. And so these are going to be things like IL-4, IL-5, IL-13, which we know are prominent, are really associated with eosinophilic diseases. So I think the most comprehensive study that's been looking at EOG was supported by Seeger, and the results were published in 2020. This study was a multi-site study that included 74 EOG patients. These patients had only gastric involvement, and 111 non-EGID controls. And they looked at both gastric biopsies and serum. The gastric tissue was all scored for the EOG histology scoring system. So we can look at the features and the histology features. They looked at the expression of genes and proteins in the tissue, and as well as looking at circulating cytokines, so both the plasma and the serum. And what they found was that, and I won't go into the results in too much detail, but EOG patients did have significant shifts in their RNA that was distinct compared to non-EOG. So this is kind of that yellow square showing genes that are significantly different than, that big blue square. And this differentiates the patients. And they've then identified that 18 genes were significantly distinct to EOG, and they were able to develop a tissue-based molecular panel. And then in terms of the 14 the 14 cytokine markers that they looked at, there were 4 that were significantly elevated in EOG patients that actually distinguished those patients from non-EOE. And these were eotaxin 3, IL-5, TARC, and TSLP. And they were able to kind of give it a score on their sensitivity and specificity, which kind of helps to develop a biomarker. And so despite, these serum markers being significant, several other studies have looked at these markers and haven't been able to find them elevated in the blood of patients with EOG. So what we know so far collectively in research, this seminal, the Seeger research was seminal in the work to understand the transcriptional shifts, so what's kind of happening at the genetic level, and that's where that molecular panel was developed. But even though they found elevated markers, it's just been very inconsistent in other research looking at EOG markers in the serum. And really, collectively, it seems to be there's a lack of difference between patients that have active and inactive EOG in regard to serum markers. And then also, there seems to be a very big overlap between cytokine levels between eosinophilic patients and those non-EGID patients. Um, kind of looking at like what can we learn from these markers outside in the blood versus, in the tissue. We can kind of look at EOE and we see that serum markers that have been looked at in EOE are kind of fall under the same guise. They're inconsistent. Some show they're elevated, some show no difference between control patients. But there is something that hasn't been looked at so much in EOG that we decided to look at, and that is the matrix metalloproteases. And so these are enzymes that actually help with collagen and involved in collagen. And it has been found that MMP2 and MMP14 are elevated in EOE patients. And these levels were actually decreased when EOE patients were treated with a topical steroid. So I think all this knowledge really ends up with what we have gaps in, right? We really want to improve diagnostic time on these EOG patients. And so the question is can we find other diagnostic or even a screening tool that can help with identifying these eosinophilic inflammation that is not requiring pathologists and tissue biopsies? We do have inflammatory markers in the tissue, and the limitation can sometimes be is that a biopsy is still required, and of course we all want some sort of marker that isn't dependent on tissue. The blood markers we have seen are just not as reliable as we would like them. So are there other inflammatory markers like remodeling markers that we could potentially look at? And then the last question for me and our group is there a local production? So really, could the stomach be giving us a little bit more of a clue of what is happening? And so we know that in EOE, we can look at what's the esophagus is secreting and find that there is this local immune response. So I won't go too much detail into the esophageal string test. I'll simply just say that when they have looked, when they were developing it, they looked at what cytokines they could measure from the secretions that were collected from the string. And they did find that eotaxin 2 and eotaxin 3 were elevated in these EOE patients, and that the protein levels of those cytokines were similar in the tissues as they were from the string. And then we've collected local sort of secretions or that fluid that's on the luminal side of that esophagus through a brushing. And so this is during endoscopy, but we'll actually brush the esophagus with this little bottle-looking brush. It looks like a bottle brush to me. And we'll collect that fluid that's right at the mucosa without breaking breaking through the skin. And we've found that we can measure cytokines from those as well. So this really points to that, eosinophilic disease is having a local immune response that can be measured. Okay. All this points to our research, so I'll kind of start diving into what we looked at and our results. We really wanted to know, could inflammatory markers differentiate patients with eosinophilic gastritis? So we wanted to look at both local and systemic levels of cytokines in patients. We wanted to understand if the local production was reflective of what we could see in the blood to potentially give hints at non-invasive markers. And then we wanted to understand, could these markers really be able to be used as a screening tool in the future with validation? So let's talk about a little bit what we collect. So we first collect blood, and this is all at standard of care endoscopies. And then we collect gastric secretions. So what our endoscopists do is they will go into the stomach, and they will sort of suction what is pooled at the bottom of their stomach. And this is prior to biopsies. So this is kind of just like fresh secretions that we're getting from the mucosa. Our cohort involved 20 patients that had eosinophilic gastritis, and these all had active inflammation at the time. Although we had patients that only had involvement in their stomach, we had patients that both had an EOG and esophageal involvement, and then we had a number of patients that had eosinophilic duodenitis as well. All our EOE patients had active EOE involvement, and this was 21. And then we did compare everybody to non-EGED controls with a sample size of 19. And a little bit of a deeper dive into these patients. Um, so the active EOG and active EOE patients, they had about the same occurrence of allergies, whether this be food allergies or environmental allergies. Across all three patient groups, there was a history of atopy, such as like asthma, allergic rhinitis, eczema, things like that. We did find that our EOG group had more PPI use than the other two groups. But as I said, a big portion, 90% of our patients had extra gastric EGEDs with eosinophil involvement the most often. But between our active EOG and our active EOE, there was no difference between their peak eosinophil counts in their esophagus, but there was a significant difference in their gastric eosinophil counts. Okay, so what did we look at? I'm going to try as we go through these graphs and the big list of cytokines, chemokines, and these MMPs to differentiate anything that had when we're talking about serum results, we'll have this little blood tube, and then anything that's coming from the gastric is going to have the stomach with the eosinophils. But we measured a pretty big breadth of cytokines, chemokines, and MMPs, and so it was 50 of them, and we were able to measure those throughout both sample types, serum and stomach. And so I'll just first jump into the gastric. I mean, I think that's kind of where we're like, is there a localized response? And so we did notice that MMPs are elevated in EOG patients. And we saw this most significant with MMP 1, 2, 3, 9, 10, and 12. And this was both compared to active EOE and non-EGEDs. And so this suggests that MMPs could be playing a role in tissue remodeling and the inflammation. So we know from past literature, whether it be in cancer, uh, lung inflammation such as asthma and our EOE, that these MMPs have an enzymatic effect on collagen. They do activate fibroblasts. Eosinophils can actually release these MMPs, which can then help recruit in more immune cells. So we're kind of showing this inflammatory cascade that is also in combination with tissue remodeling. So we also see there is a pretty dominant Th2 inflammatory reaction. So again, we see EOG patients that have significantly higher levels of eotaxin 2 and eotaxin 3. These are related to our chemoattractants of eosinophils. We also see elevated TSLP. These are going to be related to cells like T cells, which are important for your immune response, mast cells and eosinophils, which we know are involved in eosinophilic disease, as well as other immune cells like monocytes and macrophages. So really seeing a huge immune response happening that we can collect in the gastric secretions. And lastly, I'll just show even more cytokines that we are seeing in the gastric secretions, which are all pointing to more eosinophilic recruitment properties from these. And again, you'll see those traditional Th2 cytokines, IL-4, IL-5, as well as some kind of ones that are a little bit more upstream from the eosinophils, such as IL-6 and IL-10. So because we had a significant portion of patients that were EOG patients, but also had that duodenitis and had the inflammation in their small bowel, we just wanted to kind of look and I'm just showing a glimpse of the research here of does having duodenal involvement affect those inflammatory markers that we're measuring in the gastric secretions. And looking at MMPs, because those were the most consistently elevated in EOG patients compared to active EOE and non-EOE, we found that there was no difference. So meaning patients that only have gastric involvement have the same levels of the MMPs as patients that have both gastritis and duodenitis. Okay, let's jump to the serum markers. So similarly to other studies, we didn't find as many significant elevated serum markers in our cohort. So we didn't see any difference between those MMPs across the patient groups. Previous serum markers that reported in the seeker-supported data in 2020, including eotaxin 3, TARC, TSLP, and IL-5, were not significantly different between patients with active EOG, active EOE, or non-EGIDs. However, we did find some other inflammatory markers. So we do see IL-4 and IL-13, and those as well as IL-6, IL-8, and this stem cell factor. And so this is kind of pointing that we can identify some Th2 dominant inflammatory cytokine markers, and the stem cell factor stem cell factor is also known as mast cell growth factor in some of the literature. And so we can also see that we can detect some of this pro-inflammatory Th2 inflammation. So collectively, across the 50 cytokines, chemokines, and MMPs that we were able to measure, 26 molecules were significantly different in EOG patients than active EOE or non-EGIDs in our gastric secretions, and we were able to identify 6 within the serum. We wanted to look at, could these markers be correlated to eosinophil counts? And unfortunately, we did not see that. So looking at the inflammatory markers, both within the gastric secretions and the serum, there was no difference. The amount of eosinophil counts didn't correlate or didn't associate with the concentration of that marker. There were 3 interleukins that were significant in active EOG in both the gastric secretions and the serum. So this was IL-4, IL-6, and IL-10 that I have below in that box. And what we wanted to know is, do we think that what is happening in the gastric secretion is reflective of what's happening in the serum, or what we're measuring in the serum? And so we both did a correlation and a simple linear regression. Basically, this is just trying to see, if the gastric secretions are high for a patient, and are they similarly high in the serum for that same patient? And the answer is no. So we kind of are concluding that even though these are both high in the gastric secretions as well as the serum, we don't think there's a relationship between those. We think what's really feeding it is probably just having eosinophilia. Okay. So one thing that we had done, and I should have mentioned earlier, is when we first presented this research, it was a little bit more preliminary. We had a smaller sample size. And since then, we've been able to increase the sample size. And so I'll kind of just jump down to this MMP ROC curve. So what we were trying to understand is, if you have EOG and we're looking at these markers, can we really identify or predict that those are specific to EOG and not just, having eosinophilia in your body somewhere? And so what we found were those MMP3, 9, 10, and 12 had pretty good predictability. As measured by area under the curve, greater than 90% on both sensitivity and specificity, to predict that a patient has EOG. And so this is the graph that you're seeing right now is a very preliminary way of trying to understand the predictability of these markers, meaning, can we identify patients? And so this is kind of just showing, we think the MMPs are important, but what is under the works and is needed to bring in better biostatisticians than myself, that is not what I'm trained in, is to do these sort of training and tests and sort of these deep learning techniques to understand the predictability. So what is in the works is we're trying to understand, are there potential gastric markers that are the most predictive to give active EOG across our, 50? And then, can we then extrapolate that to serum markers? And the goal with these predictabilities is, could we then move this into a larger study to help validate these markers? So I know I am a little early, but I kind of want to talk about next steps and future implications. So, really, I think our biggest goal is, how can we improve the diagnostic time for these patients? We know we have, and the best way to do this is through a validation study. So taking our results, increasing this in sample size. These are preliminary results. It's just a lot of observations of what we're seeing. And then we want to see, we didn't have the ability to do histologic scoring. So, can we look at inflammatory markers and correlate with these other features of disease, not just the eosinophil counts, but kind of what is happening, at the lamina propria, what's happening with the basal zone hyperplasia, things like that. Um, I think it's good to continue looking at these more predictive markers, both within the gastric secretions and the blood. And then really, kind of trying to understand, are there other ways to collect the gastric secretions? What is something that we can do from a non-invasive point of view as for our patients? So I will end there and happy to answer questions. And thank you so much for having me.
Thank you so much, Ashley. We really appreciate you sharing all the preliminary findings as well as the background of other research that happened before yours.
Yeah, thank you.
Wonderful. Absolutely. Alrighty. So, first question for you today. What is the difference between gastric secretions and the serum that you've referenced?
Yeah, so the gastric secretions are going to be works the what is it being sort of that liquid that's coming from the gastric mucosa. So we do have to do this endoscopically, but basically your stomach is broken up to the body and the antrum. Body is closer to the esophagus, antrum's closer to your duodenum, and so it will kind of pool at the antrum, and we're actually just like kind of whatever like liquid is there, and we're kind of suctioning it, for a lack of a better word. And we end up can kind of and then that is just like a liquid that is found like at the base of your stomach. Your serum is going to be blood, and then we're spinning it down and we're collecting that kind of white, clearer versus the white versus the red blood cells, and that's what we're looking at. And so what we think is the blood is, you know, systemic, what is happening your whole body. What we're trying to do with the gastric secretions is what is happening at that organ that is really impacted by the eosinophil inflammation.
If someone is interested in participating in your study, how might they do that?
That is a really good question. Currently, right now, this was, preliminary research, and so I don't believe any other providers collect gastric secretions this way. We're hoping to submit for a bigger site to trial or study, but the only place to participate right now is at the University of Utah. But more to come, hopefully.
Absolutely, just the beginning.
Yes.
And so just to confirm that in order to get the testing that you're doing done, a colonoscopy or endoscopy has to be performed, correct?
Correct. Yes. So currently, what we have looked at is it has to be collected during an endoscopy to get to the stomach. However, I think that is something for future directions, is understanding how can we do something more less invasive, but still get at what is happening locally at the mucosa of the stomach.
Okay. Well, please keep those questions coming in. Click on the Q&A button on your screen. Go ahead and type in a question. We're going to just keep this conversation going. So people are curious. Did you look at anything in regards to eGPA? They're curious, are there markers or secretions that are different for eGPA than for EGIDs?
That is a really good question. We did not specifically look for eGPA markers. I think it would be helpful to kind of go through the literature and see if maybe there's some associations that we could try to answer that question. But with our preliminary data, we don't have anything to for those associations.
Right. Really. So, also curious, people want to know, are there differences in the secretions between children and adults?
Very good question. So we haven't, since I am at an adult hospital. So we haven't been able to look at what is the difference between adults and pediatrics currently, but that would definitely
Okay,
be a great future aim to look at. Yeah.
that's great.
In the Seeger study, they included both. And so we yeah, yeah. So we think that we could probably see similarities, but that is all future.
So people are curious about this. You have some people that are in Utah that are here on this webinar right now. And so they're curious. They're listing off their doctors' names that they're there, and they want to know if they are at University of Utah, how can they participate? And what is the age limit? For example, there's someone with a 15-year-old. Is that still considered pediatric? What's kind of the criteria for participating?
Yeah, so currently, okay, I'm going to go with the first question about the age cutoff specifically to Utah. So currently our IRB is only until age 18 is the youngest
Okay.
in our IRB. So
Okay.
our ethics committee that's our lowest cutoff for collections at this point in time. And then in terms of interest, we have an EGID clinic here at the University of Utah. So if you contacted them, we can have a research. They would be familiar with what research is being done through the EGID clinic. And then the University of Utah also has a study for you site that I believe has our EGID clinic studies associated. And so that if you were to Google like University of Utah study for you, you would be able to look at all the studies that are happening at the University of Utah or through our EGID clinic. Yeah. Hopefully that helps for anyone interested that, kind of wants to, you know, help fuel the research. Yeah.
Thank you for those additional details. Alrighty, so we've got a question here about biomarkers. So they're asking, aside from biomarkers, are there any noted symptoms or disease changes or even drug responses that seem to indicate that a patient previously diagnosed with EOE is showing signs of EOG?
Okay, very good question. So, most common symptoms for EOG is going to be extra esophageal symptoms. So, we do see people that have a little bit experiencing vomiting, abdominal pain, diarrhea. Um, I think, unfortunately, the disease is patchy. And so I think most providers really try to target inflammatory looking regions in your stomach to biopsy. So these could be things like erosions, also for like if there's any ulcers, that's definitely targeted. Um, and so I think limitations is even though providers are targeting what may look inflamed, um, the eosinophil counts might not be there to meet the diagnostic criteria. And I think that's so, in short, no, we're not really sure. In terms of symptoms, it really is still depending on this histology, which has its limitations. And I think that's why we see such a delay and misdiagnosis for up to that 3.5 years. And so this is where we're trying to really target that. I've talked about inflammatory markers, but another project I'll just briefly say is we're looking just at immunoglobulin profiles. Like, does the stomach produce immunoglobulins, which you wouldn't expect? It's acidic, right? Like you probably wouldn't have it. And we've noticed that patients with EOG also have elevated immunoglobulins. So within the gastric secretion. So there does seem to be something about, trying to pool what's happening in the collective of the stomach versus pinpointing that tiny little biopsy that has an advantage. And I think we're just at like the tipping stone of uncovering the potential for these secretions that we do and potentially that esophageal string test, right? It's trying to collect what's happening collectively versus that pinpoint. Yeah. I'm sorry, I don't feel like I answered that in a positive way. So I apologize you asked that question. We're still, but yeah,
So at this point, people are still looking to biopsy results to confirm EOG. Is that correct?
that's correct. Yeah.
Okay.
Yeah.
Alrighty. You also mentioned mast cells, and that brought up a question from people of, are any of these patients dually diagnosed with mast cell disease?
Really great question. Off the top of my head, I think we had, uh, we had one patient who had suspected mast cell and was on a cromolyn, to help, like a gastrochrome to help with, which has been thought to help with mast cells and especially in the stomach. But it was just just one patient at this point. But it is a great question.
Have you seen in any of the research you've done or literature that you've read, are people with inflammatory conditions more prone to developing eosinophilic diseases?
And when you say inflammatory, do you mean more like autoimmune or like kind of like an IBD or a celiac disease?
Those are
Or
great
more like
questions. Those specifics were not provided in the question, but there was a later question that did ask
Yeah,
about, EOG versus IBD. And oh, yep, the person's listening. So they said, yes, autoimmune is what they're asking about. Are people with autoimmune conditions more prone to developing eosinophilic diseases?
yeah, so the short answer is yes, they are. And so looking at population studies, like cohort studies and case control studies, they have been shown that eosinophilic patients, whether, most of these studies have only looked at EOE. I will just preface that. But there is a strong risk, relative risk, for having later diagnosis of IBD. That was a recent paper that came out of a Swedish cohort study that was also found to have a higher risk for celiac disease. Something that's done with the Utah Population Database, where you can actually look at genetic data and look at the whole family, has also looked at seen it with like MS and rheumatoid arthritis associations and relative risk. So we definitely see the autoimmunity being an increased risk for EOE. What we haven't seen, which hasn't been dived in too much, is those EOGs and looking at non-EOE EGIDs in the spectrum of relative risk and future risk of autoimmunity. Yeah. Another study to be done, who was ever interested.
You've talked a lot about different tests you're doing during endoscopies to be able to look at things. People are really curious. Do you think there will ever become a point where a blood test minus an endoscopy could be used to diagnose these conditions so that it could be diagnosed without an endoscopy?
Yeah. I'm hopeful. I mean, I think every researcher out there knows that this is like the ultimate goal is how can we do a less invasive, not as expensive. I mean, I don't know how uh, and reduce the number of scopes. I do feel I of course come up from a dietitian background, so I'm like doing elimination diets, and I know that every time we reintroduce and eliminate, we have to do a scope and we have to depend on those biopsies. And so my ultimate goal is always how can we reduce those. And so I am hopeful, I guess, is what I would say. I don't know if it's serum, we haven't quite found that, and it might be more reflective, but is there something else that we can do or another way of getting these collections without going under anesthesia and doing a scope is the hope. Ultimate goal.
Well, circling back to some of the discussion about overlaps and comorbidities with different conditions, we've got two follow-up questions here. Do you see a simultaneous decrease in serum immunoglobulins with the increase in gastric Igs?
So does serum immunoglobulins decrease if gastric immunoglobulins increase?
Yes.
Yes. I don't know if I have specifically looked at that in our data. Um, what we do see is there's no in terms of the some of these inflammatory cytokines that we saw in terms of like the IL-4, IL-6, and IL-10 that were both elevated in gastric secretions and serum. They were not correlated at all. So if we saw gastric secretions increasing and serum decreasing, we would at least see a negative correlation. They just didn't seem to have any relationship, meaning they weren't influencing each other. So in regards of the cytokines, no, we haven't looked at that specifically for the immunoglobulin research. But it's a good question. I mean, I'm definitely going to look at it, but
So the second follow-up question is about other comorbidities with other immune diseases. So they're curious, like what else, when you're looking at EOG, are commonly also related?
in terms of diagnoses, like comorbidities. Yeah, so I
Yes.
think the biggest thing that we see is other organ involvement in our cohort. That's not always seen in the literature that I've seen. Asthma is quite high, is going to and then connective tissue disorders can be another link that is high, as well as like allergic rhinitis and atopic dermatitis is kind of, so you have your sort of atopic conditions that have a pretty strong overlap, and then you'll have also connective tissue disorders that we see as a pretty strong comorbidity overlap.
Would you share a few examples of what are the connective tissue disorders?
Yes. Yeah. So, like Ehlers-Danlos syndrome is kind of is a pretty it would be a connective tissue disorder that we do see overlap with EOE and then our EOG cohort. Um,
Okay,
yeah.
thank you.
You're welcome.
You also mentioned IBD. So people are curious, how do doctors differentiate between EOG and IBD? And are there biomarkers for IBD to help rule something in or out?
Yeah. So IBD can affect the GI tract throughout from mouth to anus. And so, but they do present, I think, in different ways. I would not be able to know the biomarkers for IBD and how they overlap with EOG. Not my area of study. Traditionally, we look at like fecal calprotectin as a pretty big biomarker for inflammation once you are diagnosed with IBD. But in terms of overlap with EOG, I'm not sure if that has been really investigated.
Thank you. And then on the lines of gastritis, we've got a question. Someone's child has EOE, but it's currently, they're describing it as being in remission, but they've been diagnosed with chronic gastritis. So they're curious about treatment and whether it needs to be treated or if it's something like avoiding food. So any tips on someone that has EOE and chronic gastritis?
Yeah. Um, So what we've seen in our cohort, and I don't think it's been well in the has been well promoted in the literature, is that we've had patients that can resolve their EOE on diet or with a PPI or topical steroid and still have active EOG. And so when they've looked at the molecular kind of what's happening at the RNA level, they have seen that there's not really much of an overlap between EOG and EOE. And so so we're unsure of exactly like how well you can treat both of these at the same time. And so if they have chronic gastritis, I think that I would probably avoid, like as a dietitian, I'm coming in and going, okay, can we maybe like find foods that could be gastric irritants that we can remove or that are bothering them. So for commonly gastric irritants could be like alcohol and caffeine. This is a child, so we're assuming these are not. Spicy foods might be a problem. Other acidic foods like tomato-based foods can sometimes be problematic, and those are also related to like GERD, right? So kind of coming under those ideas of refluxy types of foods that might be causing irritation. And then you could also notice if certain foods, I'm not sure how old the child is, but I think always a food journal can be helpful, just to kind of help like especially if a kid is kind of experiencing symptoms daily, to kind of say, okay, well, what did you have for lunch? Let's just write that down and then give it a full week that this is what I like to do for journals. I like to give it a full week, just trying to see if there's any consistency. Sometimes I've noticed it's just about the timing too. And so it's like, are we eating too late? And then going to bed and then we're having like, something that's refluxing and we're laying down and it's making it worse. Or is it a certain food? And so that's kind of where I would go from, just like, how can we avoid maybe gastric irritants to at least reduce symptoms, not knowing if the gastritis is maybe an undetected EGID, which is where our markers are kind of, we're like suspicious with some of our patients that are elevated. Pathology is like, there's no without. And then we're like, but they're really elevated. I wonder how long it will take for this patient to come back and we actually get the right biopsy. So that's kind of where I would kind of delineate what we're doing, what to do. Yeah.
Thank you. You've made several comments about within your cohort. And so
Yeah.
people are curious. Do you think that comorbidities change depend on where someone lives?
Um, So I think something that we have in Utah is we have a lot of we have big families, and we know that eosinophilic disease has a familial component, as well as some other genetic like comorbidities like asthma has a genetic component. And so I think that what we see is we'll see large families that end up having, multiple relatives that have either an atopic or a eosinophil disorder. And so I think that's where I keep saying, like, maybe maybe our patient population's a little different just because we see these big families that have a strong genetic component. So I think that's one factor that's kind of going into maybe how where you live is impacting. It's more kind of the genetics of it. But there has been some research that definitely impacts, that has shown environmental impacts and how it can relate to the pathogenesis of eosinophilic disease. And then also kind of like, for example, certain aero allergens can then aggravate that eosinophil disease at certain times a year. And so there's kind of that both in terms of my cohort. Yeah.
Thank you for all the information and thank you for all the research that you're doing. Is there anything else about these inflammatory markers that you'd like to share today?
Um, it's a very good question. No, I think at this point, we are trying to tease this out to really try to identify kind of what are potential predictabilities. So I'd say stay tuned. Our hope is that we can tease this out a little bit more and try to help with at least, trying to help with reducing that diagnostic time. But thank you so much for having me.
Absolutely. Thank you so much for all the information and your continued support for the eosinophilic community. Thank you also to our education partners for their support of this webinar series, including Bristol Myers Squibb, GSK, Sanofi, and Regeneron. Our next webinar will focus on EGIDs in infants. So please join us back here again on December 17th at 1 o'clock. We'll speak with Dr. Hiremath about this topic. You can register for this webinar at apfed.org/webinars. Another great opportunity to continue learning about eosinophilic disorders is our annual patient education conference. So this year, while you see the July date on the screen, even though those live events are done, we recorded all of the sessions and you can watch them on demand. Go to apfed.org/conference. You can register for free virtual access and watch them on demand through the end of 2024. You can also continue learning more about eosinophil-associated diseases by subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. In our latest episode, we talked with Kate about navigating EOE in college. She is the recipient of one of APFED's college scholarship, and she recently talked with us about her experience going away to college, and it was really neat to learn that she's not only living with an eosinophilic condition, but now studying them as well. So you could find that episode and more at apfed.org/podcast. You can also listen on Apple Podcasts, Spotify, Audible, and more. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. Thank you all for joining us today. And thank you again, Ashley. If anyone has a question that didn't get answered today, please email mail@apfed.org. Hope everyone has a great afternoon.